presentation.
I think the next talk is Dr. Shreya. Can you invite her?
May I request Dr. Shreya now to give her presentation. Dr. Shreya is a very versatile surgeon and does a lot of work in ocular trauma. They have a huge volume of publications and she does a lot of ocular plastic work. So we look forward to listening to her experience on this subject.
Akshay, you are muted.
Yeah. Thank you so much, Dr. Grover sir, Dr. Namrata ma'am, Dr. Mehul sir, for allowing me to speak on this topic and nice introduction also. I'm going to speak on management of strabismus after orbital trauma. And out of our 12,687 cases, nearly 14.6% were having a orbital trauma. And this was already presented. But if we look into the strabismus, how it can happen, so it can happen due to supranuclear structure involvement, ocular nuclear involvement, extraocular muscle. So let's look how it can create the strabismus. Either it can be a direct impact on the muscle due to trauma, pressure effect or neurological, or it can be indirect and sometimes present immediate or late. So we'll talk in detail. So let's see what can happen to muscle when there is trauma. Number one can be muscle contusion. Number two can be partial laceration. Number three can be complete laceration. Muscle can be snapped or pulled into two. Muscle can have traumatic disinsertion. That can be lost muscle, and that can be incarcerated or entrapped muscle after orbital floor fracture or fracture. As we all know, it can be pure, impure, or it can be usually with the floor fracture. Like in this case, it is antral 1, elevation defect, antral 2, depression defect, and antral 3, both the defect. So we'll not go into detail of these fractures. Dr. LMM has already covered everything, but be aware of white eye blowout fracture in children, which needs immediate early attention. Eighth thing can happen to muscle is flap tear. We'll talk in detail about this. Ninth can be slipped muscle. So, and then can be any combination. So how to diagnose? We can diagnose with the gross examination, includes everything: hemorrhage, injury mark, diplopia charting, haze screening, binocular field vision, exophthalmometry, pupil examination, visual field, etc., along with the radiological investigations like USG, CT, MRI, dynamic MRI, or EMG. So that guides us very well. And be aware that children usually have a trapped or fracture. Here in MRI, muscle contusion is seen very well. But then with radiological investigation or clinical diagnosis also is important, which can be done by ocular motility, FDT and FGT. So in this boy, the FDT for elevation is positive. So first is force duction test and then force generation test, and the patient is cooperative, we can do with the Q-tip if patient is not cooperative, or sometimes we may have to take patient in OR. So this is a force duction test. For adduction is positive, you'll feel some tuck in your hand and you'll see there is generation. So here I am going to, we have our own diagnosis algorithm on clinical base. Here if you have a blowout fracture with big defect, ocular motility can be some disturbance, and FDT can be negative, FGT will be positive. Blowout fracture with small defect with the incarceration will show marked restriction in both fields, can more in opposite field. Both the FDT, FGT can be positive. Trapped or fracture in children usually can say bradycardia, vomiting, syncope, or oculocardiac reflex, and FDT will be strongly positive. FGT can be positive too. If there is a flap tear of muscle, usually produce limitation of movement in field of action. FDT can be negative, FGT can be positive. Snapped in or pulled into two, show limited action in field of action, full movement in opposite direction. FDT can be negative, FGT can be positive. Contusion of muscle may show the limitation just because of pain and edema. FDT, FGT both can be positive. Partial laceration of muscle may show limited action in the field of action. FGT can may be negative, FGT can be positive. Complete laceration usually will show limited field of action but good movement in opposite direction. FGT again will be negative, FGT will be positive. Complete disinsertion will give full movement on the opposite direction and no movement in field of action, and there can always be a combination. So how to manage? Management, before managing, you have to see about red flag sign like ocular cardiac reflex, retrobulbar hemorrhage, open globe injury, CSF leak, and muscle strangulation, which we have to work urgently. If there is no red flag sign, we can wait until we are waiting. We can see, as LMM said, we have to check patient every day. Sometimes we may have to prescribe prism or occlusion therapy. When there is muscle contusion, simple observation, anti-inflammatory, steroid, antibiotic can work. No nose blowing. In this patient, there was trochlear contusion, but it was treated very well with the medical management. Partial laceration, usually you find the muscle and it will be very good repair if you find the muscle, but sometimes the muscle is weak, so we have to add sometime a resection also. Complete laceration of muscle, here also you'll get some of the clue, or one or two fiber will be there. Remember, muscle usually doesn't go anywhere other than its muscle sheet. So aim to find out the muscle sheet. Once the muscle sheet is possible, with even with non-traumatic forceps you can hold muscle sheet, but once you hold the sheet and then you are able to get the muscle, hold the muscle with non-traumatic forceps and then suture it. This is the same patient. Next day post-operative, right eye medial rectus we found and we attached back to the insertion. The fourth can be snapped, pull into two muscle. This 30-year male had iron rod injury and the inferior rectus was pulled into two. So now we have to find out the distal end. Sometimes we may have to hook the adjacent muscles in order to trace the intermuscular septum. It's very easy to find out. Tell your assistant not to pull opposite the lost area. Otherwise, it will push it back more to the orbital area. Muscle usually you get from muscle sheath and you can see suture. This is 1 week post-operative, all movements was regained. This patient had old injury, scar tissue, FDT negative positive and FGT mildly positive. We did MRI EMG also, but when on I'm sorry for the not clear video, it's very old video. We tried to find out the muscle, we could find the muscle, and but it was very tight and it was incarcerated. It was very difficult to find out, though we found out and we attach, sometimes we may not get full movement. So be ready for such a treatment, and in that case transposition of other extraocular muscle will definitely serve. Incarceration or entrapment, as Dr. LMM already said, that orbital floor fracture or orbital fracture will say this. When to operate and where to operate, it's as I already said, when there is a flag sign. Nowadays, the routes are transconjunctival, transcutaneous, or endonasal, and many material are available, autologous titanium alloplastic, and nowadays, theoretically, this absorbable material is also available. If somebody is using, just let me know. So this boy was operated after removal of all the tissues entered into maxillary sinus. We have to take it back slowly, and then once we are able to clean, then we can put this PPE implant and glue this. So don't forget to do FDT at the end of the procedure. So there are a few patients also have got with the entrapment and incarceration. This boy, we got a call from orthopedic surgeon. So in our area, we have to go to other place also. So they called me once they have repaired their mandible and everything. They fixed the mandible. They call us. So after orbital rim fixation, we put titanium titanium mesh implant covering medial wall and inferior wall. And this is the intraoperative. Once you do that, we need to do force duction test. In this patient, we can say the force duction test still is positive. So again and again, readjust the implant and then do till the don't end till the force duction test is negative. This is post-operative video. This is intraoperative pictures and patient gain the movements. Nasal route also can be used. Complication of orbitotomy we are not going to discuss here. Eighth thing can happen is a flap tear. So this is normal. This is flapped IR and this is flap MR. So we can see this is a detailed view with the lamellar laceration, and this other part is in sometime incarcerated in the orbit. Flap tear again can be type of longitudinal type of flap tear, beveled type of flap tear, lamellar type of flap tear, and retracted type of flap tear, or sometimes the flap can be avulsed from the muscle that needs to be taken care. So this girl had a flap tear. We found intraoperatively and then we repaired, so she could do well. Management of retracted flap tear also has to done with non-absorbable suture and the lateral the slip muscle. Post-operative strabismus surgery patient had trauma on the muscle slip. Muscle cannot go anywhere else than muscle sheath. So now if you have operated very well, the patient muscle will always be in the muscle sheath. It is very easy to find out, suture it back. Sometime we may receive such kind of patient post-operative sinus surgery. So she had this kind of strabismus. We fixed all the muscle and then we could do oculoplasty management later on. Post-injections also, thick muscle can cause this. Don't forget to operate ptosis also. Sometimes vascular cause also will cause the strabismus. So if you observe minutely, this is a simple pulsation which is seen, and then in dilatation of the ophthalmic vein will tell you everything. So this patient also had a strabismus after ligation, and we operated well. Sometimes these were direct injuries, but nowadays indirect, like third nerve palsy can wait, traumatic IR palsy. This is a third nerve palsy with the aberrant regeneration. So we did superior oblique muscle transposition to the medial rectus muscle along with the lateral rectus recess and resection MR and LR procedure. So this is the 1 week post-operative, the patient could regain all the movement. So it is possible, not 100%. Deviation can be corrected later on, operated for ptosis. Third and sixth nerve palsy we can wait, is the eye usually in a primary gaze. This is fourth nerve palsy, but be aware of spread of comitants. So then we have to treat this patient as a fresh patient. Other causes can be a mechanical like symblepharon, and sometimes patient may present very late with the corneal scar, amblyopia management. Then also we can operate patient. Traumatic cataracts, after traumatic cataract we may have to operate for strabismus surgery, but be aware of this kind of pseudo strabismus. This girl is not having strabismus, like prosthesis and the lead changes. So finally, I'll conclude: thorough knowledge, thorough investigation, proper support with patients. Thank you. Thanks to my teachers. Thank you all. Thanks to my patients. Thank you.